Hello class, today we're going to talk about drug therapy for pediatric patients. This chapter is not included in your current pharmacology textbook, so this chapter and then the next 4 chapters are actually not in there, but I will include notes as well as this lecture, and all of your test questions and quiz questions will be coming directly from the lecture and the notes. So let's get started. Pediatric drug therapy is complicated by a child's age, development, weight, and lack of information about clinical pharmacology. If a label does not contain a pediatric dose, it's not okay to assume that that drug is safe for anyone younger than 12 years of age, and pediatric drug dosages may be adjusted for individual needs. Defining the neonatal and pediatric population. The neonatal period is a time from birth to approximately 28 days of age. The gestational age is the time measured from the first day of the mother's last menstrual cycle to current date. Factors in dosing for some medications may preclude use of certain medications. And the pediatric period is a wide range of ages, but it's usually from birth to approximately 18 years of age. There's different stages of childhood growth and development. In this chart, newborn is birth to 1 month, infancy is 1 month to 1 year, toddlerhood is 1 to 3 years, preschool age is 3 to 6 years, school age is 6 to 12, and adolescence is 12 to 18 years of age. Unique characteristics in pediatric medication administration. A child's body surface area, metabolism, development, and tolerance are all very different than adults. Rates of absorption, distribution, excretion, they're all different due to ongoing development of children. Safe, effective use in children requires additional pharmacokinetic and pharmacodynamic data. 20% of medications have no FDA-approved labeling for neonates, infants, children, and adolescents, and most drugs are not tested on children due to ethical reasons. Children younger than 2 years of age should not be given over-the-counter drugs without a doctor's approval, and children respond differently to some drugs. Some barbiturates, which make adults feel sluggish, can make a child very hyperactive. Pharmacokinetics focuses on how drugs move throughout the body. Neonates, infants, and children have different pharmacokinetic processes than adults do. It's important to understand the developmental differences of children in order to understand that, to understand how drugs are concentrated at the site of action, how intense their effects will be, and how long their action will last. Absorption is the movement of drugs from the site of administration into the bloodstream. Gastric emptying time and pH influence absorption rates. And in neonates and infants, gastric emptying time is slower, reaching adult levels at 6 months of age. During infancy, basic drugs are more easily absorbed from the stomach than acidic drugs, and topical medications are absorbed more rapidly by influence in children than adults. Distribution is the movement or transport of drugs throughout the body. Neonates, infants, and children have more body water than adults do. Body fat percentage peaks at 9 months of age, and lipid-soluble drugs can be stored in body fat. The blood-brain barrier. Children under 2 years of age have immature blood-brain barriers that allow easy access to their central nervous system, so they're more sensitive to drugs that affect the brain, and this also increases a risk of central nervous system toxicity. Because of the weaker barrier, large amounts of bilirubin may enter the brain, causing kernicterus, which is a yellow staining and degenerative lesions on the basal ganglia, which is also known as bilirubin encephalopathy. Metabolism, or biotransformation, involves the alteration or transformation of chemicals from their original form, aiding in eventual excretion via the renal system. Most biotransformation occurs in the liver, and in infants and neonates, liver immaturity influences drug metabolizing capacity. Drugs metabolized by the liver have a longer half-life, and there is more chance for toxicity. Excretion is the removal of drugs, active metabolites, and inactive metabolites from the body. Most drugs are excreted via the kidneys. During infancy, reduced renal excretion causes longer drug half-lives, increased possibility of toxicity to drugs mostly excreted via renal system. Especially during the neonatal period, reduced dosages are required. Pharmacodynamics is the way drugs affect the body and how they accomplish this. Drug effects may be different in infants and children than in adults. This is because of immaturity of target organs and the sensitivity of receptors. As a result, an infant or child may need either a lower or higher dose of a drug than may be expected. Fever, or paresis, is a common reason why parents seek medical attention for their children. Fever is a symptom and not a disease, and it's an important defense mechanism. Acetaminophen is usually the drug of choice in children, but ibuprofen is also another option. Childhood respiratory diseases. Patterns of disease are modified by age, sex, race, season, geography, and environmental and socioeconomic conditions. Immediately after birth, tuberculosis can be transmitted to a newborn, presenting after several weeks of life as severe pneumonitis. Incidence of respiratory tract infections peaks during the first 2 to 3 school years. And respiratory viruses such as RSV and asthma are two very specific problems. Apnea is the cessation of respiration for more than 20 seconds with or without cyanosis, hypotonia, or bradycardia. It may be a symptom of another disorder, and immaturity of the CNS often accounts for apnea of newborns, usually occurring during active sleep. Treatment for apnea includes checking that airways should be opened, and cardiorespiratory resuscitation should be initiated when a child presents with apnea. Most common treatment includes minimizing potential causes such as temperature variances and feeding intolerance. Treatments include caffeine, supplemental oxygen, and theophylline, which is a bronchodilator. Sudden infant death, or SIDS, is a leading cause of death in infants 1 month to 1 year of age. By definition, the sudden unexplained death of an infant occurs without warning in otherwise healthy appearing infants. Treatment for SIDS include clear-cut treatment measures, which are actually lacking right now, but the risk of reoccurrence can be reduced by placing infants on their backs to sleep instead of on their sides or bellies. You should minimize additional risk factors, including smoking, drinking, or drug use during pregnancy, prematurity or low birth weight, poor prenatal care, tobacco smoke exposure post-birth, and overheating due to sleepwear or bedding. It says overheating is supposed to be overheating. RSV is a major cause of bronchiolitis and pneumonia in infants younger than 1 year of age. Most important respiratory tract pathogen of early childhood, and it occurs because of the immaturity of the infant's lungs and because they have not received sufficient antiviral substances from their mothers. The treatments for RSV include Synergis or palivizumab. It's used for immunoprophylaxis against severe lower RSV infections, but other treatments also include humidified oxygen, IV or tube feeding, bronchodilators with caution, and epinephrine if the child is over 1 year old, fluids, and ribavirin. Asthma is the leading cause of chronic illness in childhood and is responsible for many school days missed. It's chronic reversible obstruction of bronchial airways. Symptoms include increased mucus secretion, muscle contraction, chest tightness, wheezing, low blood oxygen levels, mucosal swelling, airway obstruction, coughing, and shortness of breath. Treatments for asthma generally include 2 types: quick relief medications or bronchodilators, and controller medications. Controller medications help control inflammation to make breathing easier and must be taken daily. Respiratory distress syndrome, or RDS, is also called Halley membrane disease. It results from an absence, deficiency, or alteration of components of pulmonary surfactant. Surfactant is a lipoprotein complex It's an ingredient of the film-like surface of each alveolus that prevents alveolar collapse. When the amount of surfactant is inadequate, alveolar collapse and hypoxia result. Treatment for RDS include, infants are treated with natural animal-derived or synthetic surfactant if they're at risk for RDS or respiratory failure due to meconium aspiration syndrome, persistent pulmonary hypertension, or pneumonia. Continuous positive airway pressure and bronchodilators are also used. Croup. Croup is also called acute laryngotracheobronchitis. It's a viral infection that affects the larynx and trachea. It's caused by any virus associated with upper respiratory tract infection. Peak onset of croup is usually 2 years of age, and croup is signified by upper respiratory tract obstruction and thick secretions. Treatment for croup include humidified oxygen, bronchodilators, epinephrine, corticosteroids with caution, and antibiotics if the secondary bacterial infection is suspected. The epiglottis is an acute bacterial infection of the epiglottis, which causes glottis while food or drink passes through the pharynx. It causes airway obstruction. It was epiglottitis. Caused by Haemophilus influenza type B, or on rare occasions streptococci or pneumococci. The onset is sudden and infection progresses rapidly. It requires emergency airway stabilization and medical measures to avoid fatal outcomes. Treatment for epiglottitis, a visual examination of the throat contraindicated until a tracheostomy is performed. The child is observed in the intensive care area until swelling of the epiglottis decreases, which usually happens by the 3rd day. Antibiotics are given for a total of 7 to 10 days. Pneumonia is inflammation or infection of the pulmonary parenchyma. It's caused by viruses, bacteria, mycoplasma organisms, and aspiration of foreign substances. Viral pneumonia occurs more than bacterial pneumonia. The treatment for pneumonia include primarily supportive treatments, including improving oxygenation and respiratory treatments. And antibiotics are used to treat bacterial pneumonia based on culture and sensitivity testing. Hospitalization depends on severity of the illness, the child's age, and the suspected organism. Otitis media is inflammation of the middle ear. Children 6 years of age and younger are at particular risk because their eustachian tubes are shorter and more horizontal. Otitis media is most commonly encountered diagnosis for children younger than 15 years of age in the United States. The peak incidence occurs between 5 and 24 months, and then again between 4 to 6 years of age. Treatments for otitis media include first-line antibiotic medication, which would be amoxicillin or ampicillin. The second-line medication regimen includes amoxicillin with clavulanate or augmentin, cotrimoxazole, sulfasalazole, cefaclor, or erythromycin. Myringotomy is the surgical process of inserting pressure equalizing tubes into the tympanic membranes of the ears. Diabetes mellitus, insulin-dependent diabetes mellitus, or IDDM, which is also known as type 1 or juvenile onset diabetes, is caused by the complete lack of insulin secretion by the pancreas. Ages of peak incidence are 5 to 7 years and in puberty. Type 1 diabetes usually starts with polyphagia, polydipsia, weight loss, and polyuria. Long-term effects of IDDM include failure to grow at a normal rate, neuropathy, recurrent infection, renal microvascular disease, and ischemic heart disease. Treatment for IDDM. Once hyperglycemia or glycosuria is detected, immediate medical attention is required due to potential for rapid deterioration of the patient's condition. The regulation of serum glucose, fluid, and electrolyte levels, and regulation of nutrition and exercise is also a key factor in managing diabetes. For older children or children who are adolescent growth spurt, twice daily injections of a mixture of preferably NPH and regular insulin insulin before breakfast and supper may be started immediately. This chart gives the types and actions of different insulins. There's different types of insulins here on the left. There's fast, intermediate, and slow. They also list the peak and the duration of action. Treatment of hypoglycemia in infants. Symptomatic hyperglycemia can occur in newborns. They must be treated with divided doses of exogenous insulin of up to 1 to 2 units per kilogram per 24 hours. Diluted insulin is used so that inadvertent overdoses don't occur, and most children do well after a newborn period and do not appear to be at an increased risk of developing type 1 diabetes at a later stage. Seizure disorders. A seizure is a sudden transient alteration in brain function due to abnormal neuronal activity and excessive cerebral electric discharge, with causes including perinatal factors, febrile illness, trauma, toxins, degenerate diseases of the nervous system, infectious diseases, metabolic disorders, neoplasms, and circulatory disturbances. Epilepsy is characterized by recurrent, unprovoked seizures of primary cerebral origin, indicating underlying brain dysfunction. Treatments for epilepsy include anti-epileptics, which are mainstays of treatment. Single drug therapy is the most desirable, with the goal of establishing a balance between seizure control and adverse side effects. And the drug of choice is based on seizure types, patient variables, and epileptic syndrome. Drug combinations may achieve seizure control, and complete control is achieved only in 50 to 75% of children with epilepsy. Cardiovascular and blood disorders. Medications supporting normal cardiovascular functions in pediatric patients are similar to those used in adults. Digoxin, diuretics, and occasionally antihypertensives are all utilized. Patent ductus arteriosus, or PDA, is a condition unique to this population, requiring inotropic agents to support blood pressure. During fetal life, most pulmonary arterial blood is shunted through ductus arteriosus into the aorta. If ductus stays patent when pulmonary vascular resistance fails, aortic blood is shunted into pulmonary artery. PDA is one of the most common congenital cardiovascular anomalies associated with maternal rubella or German measles during early pregnancy. In uncomplicated PDA, the ductus closes spontaneously within the first weeks or months of life. When a large symptomatic PDA is present, general treatment may include fluid restriction, digitalization, correction of anemia, or diuretic therapy. Prostaglandins, such as indomethacin, may be up to 80% effective in closing the ductus. Surgery may be used when indomethacin is not tolerated or does not improve on the effect. Congestive heart failure occurs when the heart can't pump blood returning to the right side or provide adequate circulation to meet needs of organs and tissues in the body. The causes of CHF include high output state, which is usually related to congenital heart diseases, and low output state, which is related to congenital heart diseases involving obstructions, primary heart muscle disease, and rhythm disturbances. The treatments for congestive heart failure include initial management accomplished by pharmacological agents to improve function of heart muscle and reduce workload on the heart. Digitalis, or digoxin, is given to increase cardiac output, and diuretics decrease preload volume. Fluids usually restricted to 2/3 of the maintenance levels, and attention is given to nutrition and to rest. Iron deficiency anemia is most common anemia in children from North America. Not usually evident until 9 months of age, caused by insufficient dietary intake of iron, and may affect preterm infants, those with chronic blood loss, and those with vitamin B12 deficiencies. Iron deficiency anemia also affects those with sickle cell anemia, those with infections, those with chronic inflammation, infants whose mothers had iron deficiencies, and those with significant perinatal blood loss. Treatments for iron deficiency include prevention and intervention. Prevention includes encouraging mothers to breastfeed, eat iron-rich foods, and take iron-fortified prenatal vitamins. Medication therapy may consist of iron supplements to be taken orally, vitamin C, which aids iron absorption, and injected iron used only if small bowel malabsorption disease is present. Sickle cell anemia is an inherited disorder in which children have abnormal hemoglobin containing hemoglobin S. Sickled red blood cells are crescent-shaped, having decreased oxygen carrying capacity, and are destroyed at a higher rate than normal red blood cells. Sickle cell anemia can result in ischemia and tissue death. Sickle cell traits occur in 8 to 10% of African Americans. Death occurs usually between 1 to 3 years of age. However, with new treatments, 85% of affected individuals survive to the age of 20 years old. Treatment of sickle cell includes focusing on pain control, oxygenation, hydration, and careful monitoring of vaso-occlusion. Administration of prophylactic penicillin to prevent septicemia is initiated at 2 to 3 months of age and continued through ages 5 years of life. The only cure is thought to be a bone marrow transplant, and additional immunizations include pneumococcal vaccine at 2 years of age and booster at 4 to 5 years, and then the influenza vaccines. Infectious diseases or various infectious agents have effects on different body systems in newborns and children. They may be signified by diarrhea and other symptoms and include bacteremia, septicemia, acute bacterial meningitis, streptococcal infections, HIV, and AIDS. Common problems in young children. Diarrhea is a common problem in young children. It's defined as an increase in frequency, fluidity, and volume of feces. During the first 3 years of life, a child will experience acute severe diarrhea 1 to 3 times, and severe diarrhea often requires hospitalization. Diarrhea may be caused by any of the following: bacteria, protozoans, viruses, or parasites. Treatment for diarrhea is symptomatic. Antipyretic drugs are recommended for fever, though rarely needed for children. Codeine, morphine, and phenothiazine derivatives may be used for pain and vomiting. Bacteremia and septicemia. In bacteremia, bacteria are recovered from blood cultures and may or may not be associated with the disease. And septicemia is bacteremia associated with active disease, whether localized or systemic. Both may be associated with fecal infections, pneumonia, endocarditis, osteomyelitis, and meningitis. Primary bacteremia also occurs in normal infants and children. The treatment for bacteremia and septicemia may be initiated with ampicillin and an IV semisynthetic penicillinase-resistant penicillin, such as methicillin, oxacillin, or nafcillin. In some patients, the use of chloramphenicol may also be indicated. Acute bacterial meningitis. The incidence, especially when caused by Haemophilus influenza type B and group B beta hemolytic streptococci, is increasing. Mortality and morbidity are significant, but reported deaths have decreased over time. It may be caused by several types of bacteria depending on the age group of the child. Most common infectious agents causing meningitis in different age groups. The age groups are listed here on the left. So in neonates, the infectious causes include group B streptococci and E. coli. In infants, it's Haemophilus influenza type B and Streptococcus pneumoniae. And in young children, it's Streptococcus pneumoniae or Neisseria meningitis. Treatments for meningitis. Initial therapy includes immediate multiple antibiotics, including a third-generation cephalosporin, such as ceftriaxone or cefoxiamine. After an IV line has been placed and blood drawn for cultures, vancomycin with or without rifampin is usually added, as is ampicillin or gentamicin. Other treatments include heparin and corticosteroids. Streptococcal infections. are among the most common causes of bacterial infections in infancy and childhood. Group A streptococci are the most common bacteria causing acute pharyngitis. Treatments for streptococcal infections include penicillin, which is the drug of choice for the treatment of streptococcal infections. The goal of therapy is to maintain for at least 10 days blood and tissue levels of penicillin to kill streptococci. For an intramuscular injection, the vastus lateralis is the preferred site. Human immunodeficiency virus, or HIV, causes acquired immunodeficiency syndrome, or AIDS. HIV attaches to lymphocytes and other immunological cells, resulting in a gradual destruction of the T helper lymphocytes. HIV is able to reduce damaged immune functions. Infants infected through perinatal transmission from infected mothers account for more than 85% of children with AIDS younger than 13 years old. Currently, there is no cure for HIV infection and AIDS, but combination drug treatment is used, and many children are enrolled in research drug protocols. Drugs that are used to treat HIV and AIDS as well as related complications include zidovudine, zalcitabine, pentamidine immunoglobulin, trimethoprim, and sulfamethoxyl, proper childhood immunizations, didanosine, lamivudine, and IVs. That's all for this chapter. If you all have any questions, please let me know.